Just a few comments this morning. Good morning. First of all, to the out-of-towners who are tuning in, if you've been having any technical problems, please let us know. Apparently up in Prince George there were some issues with either the quality or just the inputting from here, so please let us know. We'll try to fix it. Secondly, we rolled out the Men's Health Initiative last week. Just as a reminder, if any of you from out of town or anybody in town want to be involved, please get in touch with me. It's an inclusive program. The idea is to get everyone who is interested in any issue in men's health and want to contribute to the communication, social networking aspects of this program. Please let me know. Thirdly, next, I guess this coming December 4th is the Northwest Urologic down in Seattle. Please attend if you can. And any other announcements? Not that I can think of. So I'll introduce our speaker this morning. Nick Buchan originally hails from New Zealand. He is our Uro-oncology fellow this year, or one of 2 Uro-oncology fellows. Nick did his most recent training in Brisbane in Queensland, Australia, and he is spending the year with us. He will talk to us this morning on the use of PET scanning in urologic oncology.
Thank you. So as Dr. Gomberg said, I've been here for about 9 months now, since early March, and I've been really happy about how things are going, and I really appreciate all the hospitality you guys have shown me so far. I'm here for another 6 months, so I hope that continues. Just by way of a couple of slides, I'll introduce myself. I'm from a place called Christchurch, which is just in the middle of the South Island of New Zealand here. It's a town of about 400,000 people, and I did my medical training in Otago University, which is based in Dunedin, which is in the south of the South Island, and is one of 2 medical schools, the other one being up in Auckland, which is the major centre in New Zealand. I then moved on to Brisbane in Australia, which is in Queensland, which is in the tropical north of Australia, and worked at a hospital called the Princess Alexandra, which is a similar size to Vancouver General, and you can see that on the bottom left-hand corner. Brisbane's a town of about 1.8 million people, so it's a very similar size to Vancouver. New Zealand's obviously quite famous, like British Columbia, for its scenery and also its rugby team, and also farming. And one fact of interest about New Zealand in terms of farming is it produces 1/3 of the world's exported milk supply, so it's a very big dairy farming producer around the world. So moving on to the talk, just hopefully at the end of this morning you'll be able to understand some of the basic concepts of PET scanning and underlying PET scanning, and also understand its emerging role in urological oncology. And at the end of the talk I'll go through some future research directions that people are looking at with regards to PET scanning. So what is PET scanning? PET stands for positron emission tomography, and the first PET scanner was developed in the 1950s for brain imaging. More recently, over the last 5 to 10 years or so, PET scanning has been integrated with CT scanning for better anatomical imaging, and even more recently it's been integrated with MRI scanners as well. This is a picture in the top left-hand corner is an integrated CT PET scanner, and on the right-hand side some images from that scanner. The top one being obviously the CT image, and then the PET image, and the bottom one being the married image of the two. The bottom left-hand corner is a PET MRI scan, which is available in some locations around the world and currently just used in neurological imaging. So how does PET scanning work? Basically, a radio-labelled isotope is given intravenously and becomes trapped within metabolically active cells after it's phosphorylated. Decay of that isotope occurs via release of positrons or positively charged electrons. And then gamma rays are simultaneously emitted as well in opposite directions, and this is picked up on detectors which lie in a ring around the patient. Straight lines then develop between those 2 points, and the pinpoints a source of that emission in space. The most commonly used radioisotope in clinical use at the moment is FDG, or fluoro-2-deoxyglucose, and that's been used since the early 1970s in PET scanning. And here's a schema of how uptake occurs. Basically, it's given intravenously, as I stated before, and taken up by the GLUT1 receptor, and then phosphorylated by a hexokinase, and then it becomes trapped within the cell due to the fluorine atom that's present in its structure. Here's a sort of a cartoon image of how it works as well. So there's a point source where the emission occurs, and gamma rays move in opposite directions from that source and are picked up by the detector ring which surrounds the patient. And then that digital information is transferred to a processing unit, and an image is constructed from that. The most commonly used radiopharmaceutical is FDG, as I said. Although new radiopharmaceuticals are coming online and being used more and more that are perhaps more ideal in certain clinical scenarios. There are a number of shortcomings with FDG, which I've listed there. The first one is that it is taken up by macrophages, so it can give false readings in certain inflammatory conditions, which obviously is important. It's also excreted in the urine, which is important in urological conditions because it accumulates in the renal pelvis and also the bladder, and makes assessment of both the kidney, bladder, and also pelvic nodes more difficult. And the other issue is that the cancer under investigation needs to be metabolically active, which some cancers in urologic oncology aren't, which makes it more difficult to interpret. I've listed here some of the radiopharmaceuticals that are used, the main one being fluorine-18, and the half-lives are written beside them, mainly to highlight that some of the half-lives of these radiopharmaceuticals are very short. The 110 minutes there enables fluorine-18 to be manufactured off-site, and that obviously reduces the cost to the department and the unit itself, because some of the shorter half-life radiopharmaceuticals need to be manufactured on-site in their own cyclotrons. So how is PET used in oncology? Well, it's had a significant impact on a number of solid tumours, the main ones being small cell lung cancer, melanoma, lymphoma, esophageal and colorectal cancers. And it's also played a significant role in restaging of these diseases and also monitoring therapeutic response to treatment. I've just picked out one example that's non-urological just to highlight this, and that's non-small cell lung cancer. It's one of the main clinical applications of FDG PET, and it's used in all through the clinical pathway in both diagnosis, staging, treatment planning, and also assessment of response to some medications as well. Numerous series and randomised controlled trials and meta-analyses have all shown that PET alters management in up to half the cases scanned in this condition. So clearly it's made a significant difference in lung cancer. What about urological oncology, and in particular prostate cancer first?
Quick question. So does that mean that a patient prior to surgical resection of a lung lesion will get a CT PET? Or what are these?
Certainly there's very strong evidence that that should occur, because there's a number of papers that show that some people don't go on to have surgical resection based on finding metastases on PET scan that wouldn't otherwise be found. So that's one of the ways it alters management, is that metastatic patients have found that previously wouldn't have been found based on the PET scan, and therefore go on to systemic therapy rather than having surgical resection.
Usually on the basis of metastasis or extension of the liquid?
Both, as I understand it. Okay. So in prostate cancer, clearly current staging and localisation techniques aren't great. And there are a number of clinical problems where, in prostate cancer where staging of the cancer is important and different staging techniques would be useful. And I've listed those below. Obviously the accurate detection of metastatic disease at presentation and the localisation of recurrences in patients with biochemical failure, as well as detection of tumours in patients with a rising PSA and a negative biopsy, and also localisation of tumours within the prostate. And finally, determining therapeutic response in the age of new targeted therapies. So there are a number of limitations with regards to PET scanning in prostate cancer. The first and main one being that there's a very low uptake of FDG in prostate cancer cells because of the low glycolysis rates that occur. It's also unfortunately taken up by BPH tissue and also inflammation. So this makes interpretation of results very difficult. And also there's the urinary excretion of FDG, which I've discussed previously. So a lot of people are looking at different radio tracers that have different properties that enable better sensitivity and specificities, and one of these is choline. And there's a paper that I picked out from the literature. There are a number of papers on different radio tracers, but this highlights sort of general theme. In this paper, they looked at carbon-11 choline and looked at whole mount specimens following surgical resection. And clearly, you can see there's a very small number of patients involved in the study, but from the sensitivity results and specificity results, you can see that the results weren't great. With regards to staging prostate cancer and PET scanning again has not been shown to be particularly clinically useful. MRI is better at locally staging disease than PET scanning, and it wasn't particularly accurate at detecting occult metastases either. And that's why a number of people are looking at different radio tracers, although the data on this is still in evolution. So this is just a clinical example, not a particularly common scenario, but this is a 60-year-old guy with prostate cancer. He was a smoker who, on preoperative staging, had a lesion on chest X-ray and underwent a PET-CT for evaluation of that lesion. As you can see, highlighted by the arrow there, that lesion was PET-avid and turned out on biopsy to be metastatic prostate cancer. What about in the scenario of PSA recurrence? Well, again, unfortunately, the PET scanning is limited by its inability to detect disease at very low PSA levels, which are obviously currently clinically relevant. And this is another little paper that looked at that. Clearly, again, what is a recurrent theme in all of these papers is that patient numbers are very small. But in essence, MRI scanning seemed to be better than PET scanning at looking at restaging these patients. So in summary, in prostate cancer, it currently has a very limited practical role, but it obviously has significant theoretical potential, particularly in the situation of tumour localisation in the prostate, if new, more accurate radiopharmaceuticals are found, and also perhaps with integration of MRI images as well. And then also there's the potential in the future, and a lot of work is being done currently on the use of it, monitoring therapeutic response to various targeted therapies as well, which I'll talk a bit more about later. In renal cancer, again, FDG PET has not really demonstrated an advantage over conventional CT and primary staging of the primary tumour, as it has a high false negative rate. mainly because of the issue of the FDG accumulating in the ring of pelvis. Here's another paper looking at that, just showing that the sensitivity compared with CT was pretty poor. Most studies in this situation and throughout urological oncology have been done in the pre-integrated dual modality scanners, so some of the information is a little bit difficult to interpret from that point of view, but certainly isn't that convincing in staging primary renal tumours. So here's a couple more clinical examples. This is a 60-year-old woman who was referred following a nephrectomy for a mass in the renal bed, and that was PET avid on scanning, and this is just an example of that situation here. With regards to renal cancer staging, there are a number of papers, and there is a suggestion based on these papers that PET scanning may be superior at detecting metastatic disease in renal cancer. Whether that actually alters the management of the patient is difficult to tease out from these studies, but again, the numbers in these studies are very small, and the sensitivity is relatively low, but the specificity is quite high, particularly in bone and lymph node metastases. This is another example of a 47-year-old man post-left nephrectomy who had some evidence of residual disease on follow-up several years down the track. And this, again, was PET avid, indicating recurrent renal cell cancer. This is a whole body PET CT scan of a patient with a primary right renal cancer, and highlighting some metastatic disease in the retroperitoneal nodes here, in the lung and also in the mediastinum. So in summary, in renal cancer, it has a limited value in terms of staging primary disease and has a limited sensitivity in metastatic disease as well, but its specificity is actually quite good. It's really difficult to tease out how clinically relevant that is in terms of altering patient management, however. With regards to bladder cancer, again, its sensitivity is quite poor, particularly with primary tumours because of the issue of radiotracer accumulation within the bladder. And people have attempted to wash out the bladder using oral hydration or also furosemide, but that has had fairly mixed results. Again, they're all small studies in the pre-dual modality era. With regards to bladder cancer metastases, there's a few papers coming out more recently, this one from 2009, which suggests there might be some benefit from doing PET scanning in this situation. Again, a small study, but prospective, and all these patients had negative conventional imaging, i.e. CT, preoperatively. They went on to have a PET scan preoperatively, and a positive PET scan was confirmed by biopsy or lymphadenectomy, and a negative scan was confirmed by either lymphadenectomy or clinical follow-up at 15 months. And of interest, it had quite a significant negative predictive value, which obviously is important, but slightly low sensitivity. Again, very limited numbers, however. Just 7 of the 42 patients had occult metastases. However, you've got to remember that these patients were already screened by CT, so it may have some value. And of the 3 patients that were negative on PET but found to have nodal metastases, all the volume of the disease was less than 1 centimetre in size. So in summary, in bladder cancer, in terms of staging the primary tumour, not particularly useful. In terms of detecting distant metastases, there is some evidence emerging that it may be useful in that situation, although further studies are needed to evaluate that further. And then there's its role in monitoring therapy and restaging, which hasn't yet been validated or established. In testicular cancer, which is, seems to be the main role in urological oncology, where it's established itself, one would expect a major role for PET because of the high cell turnover rates you get in germ cell tumours. And as we know, 30% of clinical stage 1 non-seminomas on follow-up have retroperitoneal nodes, and 20% of clinical stage 1 seminomas have relapsed in the retroperitoneum during surveillance. So clearly more accurate staging would be of an advantage, particularly in terms of advising patients with regards to surveillance, and also avoiding some of the side effects of the 80% of patients that are truly T1 N0. So this is some clinical examples here. These are both post-chemo patients. The top one's a post-chemo seminoma patient who on follow-up had avid lesions here, which we'll talk about in a moment or two. And this is a non-seminoma patient post-chemo who had some avid lesions in the retroperitoneum as well. So in terms of staging testicular cancer at diagnosis, PET doesn't seem to be of any value over CT scanning, and this is mainly due to its the possible presence of teratoma and low volume disease. All these studies were done in the pre-dual modality era, so perhaps with the dual modality machines currently this may be improved. This is a setting where PET scanning has a real role, and it's in the post-chemo residual mass, and it's pretty well established that this is of clinical relevance. It's important to do the scan at least 2 weeks after the cessation of chemotherapy to avoid false negatives from chemo-induced suppression of metabolic activity, and also false positives from inflammation in the tumour. This is the sort of sentinel study, although there's a number of other studies that have repeated these results. That's the SEMPET trial from 2004. There's 51 patients involved. It was a multi-centre trial, so it just shows that it's difficult to recruit patients in this setting, just numbers-wise. But in essence, PET scanning correctly predicted all 19 lesions that were greater than 3 centimetres as being either negative or positive, and in lesions greater than less than 3 centimetres, sorry, correctly predicted 35 or 37. So pretty good results. And this was compared with CT scanning and was superior in all areas. With regards to non-seminoma tumours, well, it still has a potential, but it's limited by the fact that there's the potential for teratoma, and teratoma doesn't take up PET particularly well, radiotracer particularly well, and has similar appearance to normal tissue or fibrosis. So in the setting of residually elevated markers or progression of a mass on CT, PET doesn't really add that much to the decision-making process, but perhaps in patients with tumour marker negative disease or a stable mass on CT, a positive PET certainly makes it highly likely that they have viable cancer present, but a negative study tends to indicate that there may either be teratoma or just normal tissue present. So I'll just move on now to talk about a few slides on possible future directions in terms of PET scanning and in general, and also in urology. Clearly, there needs to be more studies. Not sure what's happened there. Oh, that's better. Clearly, there needs to be more studies in terms of integrated PET CTs in urological oncology. The numbers aren't huge, and it's difficult to interpret the results in terms of their sensitivity and specificity because of that. There are a number of novel radiotracers being developed in all the urological tumours, but in particular prostate cancer and also renal cancer as well. And one of those is citrate-based tracers, which are currently being trialled, and results are awaited. The development of radiotracers that remain in cells beyond the excretion time would obviously give better delayed images of the renal tract as well. Some researchers are now linking monoclonal antibodies to positron emitters as well, and trying to selectively target particular cell types, particularly with regard to even treatment of those particular cancers as well. Not in urological oncology currently, but certainly in some other tumours this is being developed. And the integration of PET with MRI images may obviously have a role in localisation of prostate cancer within the prostate in the era of the push towards focal therapy. One area where there is certainly a real growth in PET scanning is in the monitoring of therapeutic response to certain treatments. And its role in the setting has been quite well established in non-small cell lung cancer, breast cancer, esophageal cancer and lymphoma. And it correlates very well with clinical outcomes. And it allows early assessment of response to various targeted therapies, even days after the initiation of those therapies. And it can and has been used in the setting of drug trials to assess response to certain drugs. And in prostate cancer, its use in this setting is currently being validated. So that's the end of my talk there. I'd just like to acknowledge Nathan Lorenchuk, who's a colleague of mine from Melbourne in Australia, who's done a lot of work on PET scanning, particularly in renal cancer, and he works out of the Austin Hospital in Melbourne, and also the PET scanning research unit in Melbourne. I'd like to thank him for the images.